So a complex intervention can be complex because of the properties of the intervention itself. So it might have multiple components, or it might work in different ways. It might be complex because of the way it's delivered. So it might require actual expertise and skills in terms of delivery. And it might actually be complex due to the way it's implemented. So if there's a flexible implementation strategy, then that might be adding layers of complexity to something very directly as well. And there's lots of guidance out there about how to develop complex interventions, and in particular the new Medical Research Council guidance that came out last year is really a great guideline of how to go about this process. And I was just going to say a little bit about that MRC framework, but then really talk about a practical way of maybe thinking about intervention development. So this is from the latest MRC framework for complex interventions. The old framework before last year, focused on developing the intervention, testing its feasibility, evaluating and implementing it. And now the new framework has recognised the importance of context, as I mentioned before, and the importance of engaging stakeholders and actually refining the intervention and economic considerations as well. So these are some of the newer elements that have been brought in. And previously, most guidance about complex interventions focused on efficacy, so whether the intervention worked in ideal conditions or whether it worked in real world conditions, the effectiveness. But what this new guidance has brought in has been a little bit more around theory based. So what works in which circumstances and how, so very much a realist kind of slant to that, and also taking a systems perspective, so how the intervention adapts to the health system and how the health system also adapts to actually incorporate the intervention. So that's a little bit of an overview of the background to complex interventions. And really what I wanted this talk to be is much more of a practical guide to look at some of the methods that I've used for designing complex interventions and some of the theories and models and frameworks out there, and how we might go about articulating these through a theory of change, conducting process evaluation, and then how we can think about achieving policy actions. So my background has really been working with grassroots organisations in global health, particularly in rural India, but also in sub-Saharan Africa. And some of the key things that I found that are really important to do at the start are to engage the key stakeholders. So going back to the bridge and actually thinking who needs to be involved and why they need to be involved and how. And sometimes it's very comfortable when you're designing an intervention to only invite stakeholders who you know that will buy into your intervention, but it's really important to have people there who have a different point of view, so you can get some of that pushback and actually think about all those other considerations. So once you've identified the stakeholders and thought about how they should be involved, I think it's really important then to do really in-depth contextual work. And when I'm talking about complex interventions in this talk, I'm really thinking about interventions which are social, so involve the community and wider health system. So the advantage of doing really in-depth contextual work is that actually through the observation of communities, you can really build trust, and you can also start to identify what their needs and priorities are. And one way of incorporating those needs and priorities is to think about methods that we can use to do that. And one method that can embed those priorities and embeds empathy is something called human-centered design, which I think some of you will know a lot about already. And human-centered design really comes under the umbrella of participatory approaches. And participatory approaches involve active involvement of and empowerment of stakeholders, and so can actually co-create and design interventions together with the people who are going to be using the intervention or benefiting from it, or those who have the power to actually fund and bring the intervention into the health system. And the advantage of involving people early in co-creation is that people get this sense of shared ownership, which means it's much more likely to be sustainable within the community. And so if you think about policy actions, governments often change every few years, but communities stay there throughout time and history. And so if they have a sense of ownership in and stake in the intervention, it's much more likely to succeed and to actually sustain through that time. And one of the other things that you can achieve through involving people in this process is local leadership. So participatory approaches are really pragmatic from my point of view. They're really relevant to communities and they become locally embedded. And they also have an ethical rights-based approach to them as well, because you've involved everybody in the design. So going back to human-centered design, which is one of these types of approaches, there are 4 key principles of human-centered design, and these are the ones outlined by Don Norman, which is that it solves the root issues of a problem and it focuses on people, so it can embed empathy in it. It takes this systems perspective and it involves continuous testing and refining to meet the needs of the people who are going to benefit from it. So you can see that there are some overlaps with that MRC framework as well, in terms of the systems perspective and this iterative approach as well. Sorry. As well as considering those 4 points with human-centered design, there are other things that we can consider when we're thinking about designing and developing a complex intervention. And some of these are really opportunities. I'll just give an example of something that's happened during the pandemic, which is that actually, the pandemic caused huge problems for lots of health systems. But what it also did was provide opportunities for people to develop complex interventions and get procedures in place. And one example is oxygen supply chains. So previously in rural India and in sub-Saharan Africa, some of the smaller hospitals didn't have very reliable oxygen delivery services or supply chains. But it became really apparent during the pandemic that actually oxygen was a huge priority. And so these supply chains have actually been developed in a very short amount of time. And that has been an opportunistic and an incremental step that's negotiated these tensions between the policymakers, the economy, and the social, cultural, and variables. So when we're thinking about designing and developing complex interventions, there are sometimes these opportunities that present themselves. And so we can think about taking those opportunities and developing our intervention incrementally within that context as well. Another point that I think is really important to consider comes to that last feature of human-centered design, which is really feeding back to communities what you're doing and actually in a language that they understand and having that transparency towards them, because that really is the way that you can sustain trust between what you're doing and what the community needs. And then finally, taking into account cultural sensitivity. So often that's neglected in terms of intervention design in sort of very in the guidance that you can see out there. But every community and health system has its own history, it has its culture, and it has its own belief system. And so when you're actually designing it, it's really important to understand those and to be really considerate of those as well. So that's a bit of background to human-centered design. What do you actually do when you do it? So human-centered design has 3 main phases. The first phase is inspiration, and that's going back to that really in-depth contextual work. So actually going to the communities, living with them, or going to the health system and immersing yourself in the field. And from that, you'll understand a bit more about the problems and the dilemmas that need addressing. And from that, then you can get ideas and move on to the next phase of ideation, which is when you bring together these key stakeholders and have what's called sort of blue sky thinking sessions, which is how might we do this? Or what if we had all the money in the world? What would we do? And from that, you can brainstorm and come up with some ideas and take forward a couple of those ideas to implement in practice as pilots. And this is an iterative cycle, so you can keep going back to your inspiration, ideation, and then implementation phases. So that's a little bit about how you can embed the voices of communities and take the systems approach to looking at the design of interventions and thinking about culture and history as well, and using opportunities. And then the next way of really increasing your chances of success in this complex system is the use of theory, and I'm not sure about everybody else, but I used to be really scared about the word theory and never really understood it. But actually, I think it's really practical. And theory, all it does is provide an explanation of what's happening. And it can also be used to predict what might happen in similar situations. And there's loads of different theories out there, and it depends on what you're trying to actually achieve through your complex intervention. But for example, one of the theories or models I've used has been looking at behaviour change, and I've used the COM-B model in order to address that. So what that might look like in practice. So this is the COM-B model by Susan Mickey and her team at UCL. And what this sort of states is that there are 3 conditions that need to be in place for behaviour change to occur. So people need to have the capabilities, the opportunities and motivations in order to enact a behaviour, for that behaviour then to change. And so when we're thinking about how this applies to complex interventions, we might, during our contextual work and ideation phase of human-centred design, have found a problem affecting a community. So I'm going to give an example of a village in rural India where one of the problems identified was that there was inadequate spacing between pregnancies. So women were getting quite unwell in between pregnancies, and they weren't going to get postpartum contraception. So the behaviour change that we might want to achieve in this particular scenario is that we want to get women to go to the nearest clinic to get postpartum contraception. So when we're thinking about the contextual work, we might think about how we can think about their capability. So do they have the physical capability to walk from their home to the clinic to pick up the medication? Do they have the psychological capability, the knowledge that they need to take postpartum contraception? And then think about the opportunities for them. So do they have a clinic nearby that has postpartum contraception, so the physical opportunity? Do they have the social opportunity? So is postpartum contraception, is that socially acceptable for that community? And are there some barriers to actually taking postpartum contraception? And then thinking about the motivations of the women, and that might be intrinsic motivations. Do they really want to take contraceptives? And extrinsic motivations. So do they have pressures from the outside that might make them more incentivized to take the contraception or de-incentivized? And so you can see that when we identify these barriers to behavior change, we can then design our intervention to overcome some of those barriers to capability, opportunity, motivations. And we can also enhance some of those features through our intervention design as well. So that's how theory can be used in this process as well. So we've done our contextual work, we've embedded the end user voices through empathy, we've used theory, and then we're actually developing our intervention now. And we've actually put together the components that we know might work for this intervention. And then it's really important then to actually think about what are the components and how they work. And one way we can do that is actually thinking about a theory of change, or some people like to use program theory or a logic model. But theories of change really look at sustainable systems level change. And I think you're going to hear a lot more about this in a couple of weeks from Ben. And a theory of change reflects on the big picture and thinks about what change you want to achieve, the context in which that change is going to happen, who or what is going to change, and then who do we need to work with? So who are the stakeholders involved? So some of this we would have done earlier on in our intervention design, and some of this we do iteratively as we move through the process. So developing a theory of change, what's the long-term goal? So you always start with the end in mind, and what conditions need to be in place to achieve that goal, and then thinking about what interventions might work. And they might be existing interventions that are evidence-based, or they might be new interventions that we're designing and creating. And then thinking about how we actually measure that process and develop indicators for that, and the timeline and resources involved. And at each of these steps, we need to identify who the stakeholders are and the underlying assumptions. And what happens when we do that is that we can get some clarity on the process, which might seem quite linear, or it might be a little bit more complicated. And we can bring in the theory and models and frameworks into that to look at the actual causal links and the mechanisms of action of the intervention, between the intervention and the outcomes that we're trying to achieve. So once we've articulated all of that, then we can think about evaluating it. So I'm just going to give a quick overview of a project that I did for my DPhil, which was on maternal health care in rural India. It was in 2 very diverse states in India, looking at high-risk pregnant women. And so it was a complex system affecting community health workers, primary care and secondary care as well. And this was my DPhil. So the first part was around the design of the intervention, and then the second part was on actually developing the complex intervention with community health workers, and then went on to evaluate it using a pilot cluster randomized control trial in 2 different states, and to then do a process evaluation using another theory, which I'm going to talk about, which is normalization process theory. So it was a complex intervention because it had multiple components delivered in a complex way, in a flexible approach. I went on to evaluate this intervention using a process evaluation, which looks at both the feasibility and acceptability, but also the fidelity to intervention practices. So did the community health workers deliver the intervention as intended, and what was the quality of their implementation? And then thought about the mechanisms of change and unintended consequences, and then how it could be refined further. And one of the theories that I used to look at this process evaluation was a theory of implementation, which is called normalization process theory. And that was really to understand and explain how the complex intervention came to be implemented. And going back to that area that we started off in, is really recognizing that health systems are these complex and adaptive social systems. And so when we introduced the intervention into that, I really wanted to know, how does it get implemented? How does it get embedded in that health system? And then eventually, how does it get integrated into the day-to-day work? And that's what normalization process theory really looks at. So when we're thinking about embedding a complex intervention into a health system, there's really 3 components involved. The people that are using the intervention need to actually believe what they're being asked to do is useful to them. So that's got to do with their attitudes to the intervention. They have to intend to use it. So they need to actually want to actually use the intervention. It doesn't need to cause them extra headaches or extra work. And then finally, they do the work to actually enact the intervention. And normalization process theory focuses on the work that people do. So it's not what they think they're going to do, what they say they're going to do, it's actually what they do. And it looks at this both at the individual and the collective level. And it addresses activity on 3 different levels. So at the micro level, it looks at how people use and operationalize a complex intervention. And at the meso level, it looks at how people work together to achieve the goal of implementation. And then finally, at the macro level, it looks at the wider social context in which the intervention functions. And so by understanding all of these levels, we can then think about how best we can refine the intervention in order to make it more applicable at the micro, meso and macro levels. So going back to the study that I did, I looked at the 4 constructs of NPT and actually thought about how the community health workers actually understood the intervention and how it differed from their day-to-day practices, and then looked at the relationships that changed as a result of introducing this intervention, and then thought about how they renegotiated their roles with other players in the health system, and then finally how they appraised the value of their work and the intervention practices. And so NPT for me was a really useful tool to explain some of these factors that contributed to this intervention becoming embedded into the day-to-day work of these community health workers called ASHAs. It also helped to explain the change in organisational culture and professional roles, and also to look at the feasibility and acceptability of the intervention. So I found that this theory was really practical in this sense, because it helped me to explain some of the ways in which the complex intervention had come to be embedded into the day-to-day lives of the Ashas. So you can see that from this sort of ways of evaluating complex interventions, that we can start to then develop an evidence base for our intervention. So the evidence base for the intervention is the what of what is being implemented. So it's really about defining the intervention and the components of the intervention, and looking at how we evaluate that, both in terms of demonstrating if it works in an ideal setting, so the efficacy, whether it works in a real world setting, so the effectiveness. But what's really important, I think, if we want to achieve sustainable change, is actually to think about how it's implemented and what are the barriers to implementation. And that is really one of the areas that can influence policy. And so that kind of aspect of it is thinking about implementation strategies, and that's the how and the why of how an evidence-based intervention gets into routine practice. And so if we can demonstrate both of these things, so we can demonstrate that our intervention works in a real world setting, and we can actually say, and these are the strategies that we have, that we can actually overcome these barriers and it can be implemented in our day-to-day lives, then we're much more likely then to actually make a kind of an argument towards governmental agencies, for example, to get our intervention embedded into daily practice. So this then takes me to policy actions, and I'm still learning a lot more about this. So it'll be really, it would be lovely to hear from people who've worked in policy who are on this call as well. But policy is a plan for future action adopted by a governmental entity and formulated through a political process. So, so often as researchers, we really think about just showing that our intervention has an evidence base and we want to build the evidence. But actually, when we start to think about the political process and involving that, then we can really start to think about sustainable change and embedding within the health system. In particular, when we're working in health systems that have government funded hospitals, if we can get our intervention recognised and that it works and that it can be implemented in a way that might be cost effective for the government, that might be one way of ensuring sustainability in the future. So one thing that has recently been done to look at this, where we've managed to get policy level change from grassroots level, has been some work that we've been doing around childhood malnutrition. And this involved a roundtable of all the key stakeholders, right from grassroots organisations to policymakers. And one thing that I found really was quite striking during this was that actually it was the narratives of the people on the ground, those grassroots organisations, that I think impacted a lot of the policy changes that have subsequently taken place. And so I think going back to those principles right at the beginning is about hearing the voices of people on the ground. Going back to the bridge that got blown up, if we had listened, if people had listened to the boatsmen, there would have been possibly a lot of cost savings and time savings associated with that. And it's those narratives that are important in designing interventions, but also that are important in achieving that policy level change. So I think that I'm just going to summarise now. So I think that in conclusion, co-designing complex interventions with the community can help with implementation and sustainability. I hope that during this talk, I've sort of explained some of the ways that we might think about that using ways of methodology such as participatory approaches and theories to explain how complex interventions work. And then the importance of articulating those intervention components and developing a theory of change so we can then evaluate and reiterate our intervention more easily, and bringing in those narratives and the key stakeholders so we can actually start getting the evidence base together with those powerful stories to actually make a difference to policymakers. So I'd like to end with a quote. So this is a quote from an NGO I used to work with in the mountains. And I think it kind of embodies what we're trying to achieve, which is actually at the end of all of this process, You want to be able to leave the health system or leave that particular area with people not even knowing that you were ever there. So this is go to the people, live among them, learn from them, love them, start with what they know, build with what they have. But with the best leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves. So thank you very much. If anyone's got any questions, really happy to take those. Thanks.